In chapter 30, we talk about dental sealants, and this starts on page 711 in your textbook. Some of the objectives that we'll be discussing are discussing the purpose of using dental sealants and where they are placed. We'll talk about the indications and contraindications of placing sealants, which basically means why we would place sealants and why we wouldn't place sealants. We'll explain how the dentist decides where and when to place the dental sealant and discuss the role that you would have as a dental assistant in the placement of sealants. We'll also talk about problems with placing sealants and describe the steps of the application procedure. So, the indications for sealants or why we would place sealants is because they can be effective in the prevention of caries in the teeth that are susceptible to caries. Now, remember, anytime we say caries, we're just basically talking about decay or cavities. Um, Sealants are only applied to caries-free or cavity-free teeth, and they are usually applied on the occlusal pits and fissures on primary and permanent teeth. They are also applied on recently erupted teeth or on patients that have a high number of occlusal caries and deep fissures or grooves in the teeth. And they are usually placed as a preventative treatment so that caries or decay doesn't start. Reasons why we wouldn't place sealants are on teeth that have been caries free for 4 or more years. So if that's the case, that means that the patient is actually doing pretty well in keeping those grooves clean, and there doesn't need to be any additional treatment for those teeth. Also, teeth with shallow open grooves, unless teeth really have really pronounced grooves, there's really no reason to place sealants. If the grooves are shallow enough, usually the toothbrush bristles can get there or can clean in that area well enough. Also, in patients with well coalesced pits and fissures, that just means well blended, so nothing really too deep. Or in patients with occlusal decay or have occlusal restorations. If there's already decay that's happening, or if there's already been a filling placed in that area, we can't put a sealant on top of that. So, as a dental assistant, you would either be assisting the dentist in placing these, or placement of sealants can also be placed by the dental assistant as an advanced chairside functions. So, it really depends on the state that you're practicing in. Arizona happens to be a state that us as dental assistants can place the sealants with as long as you have adequate training. The dental assistant who is legally able to place sealants must have additional training in this procedure. So we'll go over that now, as far as and also in lab as well. So the way caries and sealants work is they are first placed to prevent decay in teeth with deep pits and fissures. And they're placed second as a preventative approach to areas that have early cavitated carious lesions. And there's a little bit of discussion or maybe controversy about that second approach, and that's because if you cover areas that where the decay has already started, you could potentially be locking that decay in. So the only place it has to go is down, especially if the sealants aren't placed correctly. And if you place them over a decayed part of the tooth, it's possible that the sealants will leak underneath, and decay can still happen. So usually, especially in modern times, they're usually only placed for that first reason, and that's to prevent decay in teeth with deep pits and fissures. So there are several effective materials that can be used as sealants. There is actually special sealant material that's sort of like dental composites. In fact, dental composites can be used as sealants, but the materials used will generally last up to 10 years. So newer color changing sealants help to ensure that all surfaces have been treated. Like I said before, there's actually specialized sealant material that's more opaque white in color, so that the person that's placing the sealants can easily tell that all of the grooves have been covered. Bonding and etching are the type of I guess ways that the polymerization occurs. And what that polymerization means is that these materials have to be cured in some shape or form. When they first started coming out, they were chemically cured, where there was a part A and part B that needed to be mixed. And nowadays, it's a light cured, flowable material that comes in a syringe. You flow it over the tooth after the tooth has been conditioned, and it is cured with a UV curing light that we use in the dental office. But before that, the tooth needs to be treated by a mild acid and a conditioning material. And what that acid does is it basically just etches the tooth surfaces that's going to be receiving the sealant. It just helps to adhere to the tooth better. It helps the sealant adhere to the tooth better, excuse me. So going back to that bonding, etching, and conditioning, bonding is the process of attaching to the tooth surface. And we talk about mechanical bonds, or chemical bonds rather, but in a microscopic level, what's happening with that chemical bond is a mechanical bond, in that when you etch the tooth, it creates these little microscopic grooves or an etched surface on the tooth, so that there is a mechanical retention with the bond itself. Once the tooth surface is etched, it's prepared by removing some tooth matrix to allow a better bond. And that's basically what that acid etch does. It just removes a little bit of the tooth matrix and creates these microscopic, teeny tiny holes in the surface that allows that sealant to adhere to the tooth better, and create that better mechanical bond, if you will. With the curing process, we're talking about chemically cured materials, which were that older type of material that was used before. But like I said, more modern times have brought in flowable light cured materials. They're just easier to place, and they're more reliable. So like I said before, sealants must be placed on teeth that are caries free. You cannot place sealants on a tooth where decay or caries has already started to set in. So usually they are placed on children with newly erupted molars and premolars that are caries free, or partially erupted teeth can also be sealed. When we say partially erupted, that means that the tooth is pretty much in the mouth. And as long as it doesn't have any flap of tissue covering the occlusal surface that interferes with the application, those teeth can also be sealed. And the reason we want to do this is because if newly erupted teeth that have obvious deep developmental grooves, we want to nip any possibility of occlusal cavities or caries on the chewing surface of those teeth by filling in those developmental grooves with a sealant. And like I said before, also, if those grooves are well coalesced or well blended, usually sealant is not needed or recommended. So what is used to etch a patient's teeth? That's that phosphoric acid or some other type of acid. They usually come in like a blue, sometimes they're a yellow form, but that's usually a different type of acid that's used outside of the mouth. Usually intraoral acid etchants are blue, or sometimes they're always blue, but they're usually a blue gel, but sometimes they're also a blue liquid. Some problems that we sometimes run into with sealants are voids or air bubbles where the tooth isn't properly etched. These air bubbles can happen even if the tooth is properly etched. And like I said before, this new sealant material comes in a syringe, and it's like this creamy gel that flows out. And sometimes if you press down too hard, you can dispel a little air bubbles that could be trapped inside the syringe. So you always want to make sure that you're flowing that material onto the tooth surface gently and slowly. Sometimes the sealant doesn't bond properly due to the presence of moisture. And that's so why we kind of want to have that four-handed dentistry. It's really nice, especially when we're dealing with little kids um, or sometimes these little kids can be a little unruly, or sometimes we have adolescents that have lots and lots and lots of moisture in their mouth. So four-handed dentistry is really nice to be able to get through these sealants without having too much moisture introduced to the surface of the tooth. Um, Sometimes too much sealant interferes with the bite. So like I said, the sealant material needs to flow into the developmental grooves of the tooth, but you shouldn't put so much sealant material that that patient can no longer bite down. So I always like to say I always like to say less is better when it comes to sealant. So all you really have to do is just fill the deep the deepest part of the developmental grooves, but you shouldn't fill up the whole tooth completely because then your patient won't be able to bite down. Sometimes also chips or leakage at the margins of the sealants can happen. And this is especially problematic because these sealants are designed to completely seal up these developmental grooves. And because a lot of the newer sealants are white or opaque, you can't see what's going down on the underneath the sealants. So if these sealants start to leak, um, that means that caries has undermined these fillings, and to the point where the dentist can't see it or can't check it on a regular basis until it starts to show up on an x-ray, which usually means that that cavity has already eaten away a large portion of the tooth. So that's why it's really important to keep the area isolated and dry when we place these sealants. We want to make sure we properly etch the tooth surface, and we don't want to cut any corners when we're placing sealants because we don't want these things to leak at the margins at the end of the day. Okay, so that's all I have for chapter 30. And then you will learn more about these in lab. All of this will become a lot more clear when we start to actually place these. Okay, so good luck in lab. See you soon.